Good morning. Hello to everybody. And I didn't click, but that's okay. And first, I wanted to say happy birthday, because that's the 10th anniversary. I feel like we are just starting. And as you showed, this is very impressive, the pie charts. I mean, when we started that 10 years ago, and even a little before, in this place, actually, our aim was really to gather all possible goodwill to change the status quo in this field. And so we're so happy to see that many communities coming along. You see here, let's say, the historical roadmap. And we divided that in two parts that are going to merge moving forward. On the top, we started here at Institut Pasteur, trying to understand what a twin of a cell could be for onco. And Dr. Pécuchet did the final keynote at the time on this. And then Living Heart came, and we understood that multi-scale, multidiscipline was something reachable. And as you said yesterday, everybody thought it was impossible. It was like unreachable. And pretty much like Bernard said for the aerospace, you are the proof globally that this is achievable and replicable. We did that with Living Brain, and you are going to see today also Living Eye, Living Lung, and forthcoming projects. And I will expand that this MOD, SIM, and AI approach, this is one of the purpose of our collective effort and our collective partnership and alliances that we are forging. We are already jumping to the conclusion. This is a call for action for everybody and a call and request for action. We want to initiate more and more of those kinds of projects with you guys on all possible topics. Onco, cardio, neuro, nephro, ortho, you name it. Because in the end, we are not going to do the human virtual twin by ourselves. It's going to be necessarily collective. And of course, not only ModSim, it's data. And you see at the bottom a second swim lane, which is our effort and our partnership and alliance with the Medidata company that we acquired in 2019, which brought us a maturity and understanding and a know-how of how we could, let's say, apprehend, consider the patient data, not only during clinical trial, which was the first setting for Medidata, but in the long run, before clinical trials, when we are in good health, after clinical trial, for a lifelong engagement. And those two sets are going to converge, because moving forward, our ambition is, of course, to transform medical practices with twin, but not only for the patient when they're ill, but every time during the life. And why so? I presented this slide, I think, last year, but we always start with this one, because we believe we need an integrative representation for organs, for cells, multi-scale, multidiscipline. And there is an analogy that I always mention with aerospace, but to make a long story short, in documents, we may put some information, but by definition, a document is a closed space. And therefore, we can relate with other documents, but that's not easy to do, as opposed to a model, which by definition is integrative if we structure it that way. And so that roadmap, that conceptual segue from documentation to imaging, to multimodality integrated in a model, and to experiences leveraging the power of the modeler, the modeling, the simulation, and of course AI, is, if you will, our conviction. We are not saying we are going to replace EHR. We replace blueprints and drawings in aerospace. But we believe strongly that twins are going to be a necessary complement for the medical practice, for the practitioner first, for them to understand really, and with the medical staff to communicate and collaborate all together, but ultimately also for the patient to understand what's going on. And this is, I believe, what also our friend from Gustave Roussy said yesterday. And from the data perspective, this is taken from our Medidata Worldwide Conference. Our ambition, and we announced it, is really to start to consider and collect the worldwide multimodality of health data, not only the very structured data coming from clinical trial phases. So everything coming from EHR, imaging, quantify self, clinic visits, you name it. We are going to expand the capability of what we have in the company as a platform, which is industry grade, which is cyber grade, which is HDS in France. We have all the norms in terms of security to provide a holistic grounding for that data to be injected in models for practitioners and patients. So you see those two lines converging, and this is the long-term, with short-term actions, of course, for Dassault Systèmes. So let me show you a couple of things that we are already starting at research projects. Some of them, of course, you heard of them, and you are going to see outstanding talks on TwinOnco and Living Lung and Living Eye and MediTwin. Let me show you a couple others. And again, our strategy, and I know we named that conference Virtual Human Twin, Virtual Human. But for us, if we talk about twins for health, we cannot dissociate the human twin with the health system. And therefore, there are, like, if you will, a threefold, a ladder with 3 stages. It's a rocket with 3 stages that we are tackling. All the projects related to all the scales for the living, from molecules to cells to tissue to organ to human to cohort to national populations, but also the care systems by itself. So hospitals, how do we twinify a hospital? Some would say it's like a plant. I'm starting to disagree. A plan is you need to always be on a nominal and correct the non-nominal. I have the impression that hospital is quite the other way. You're always non-nominal and you try to be nominal. And at the higher level, which is a little more, let's say, involved, we all face this question of sustainability of the health system by itself from an economical standpoint. How do we twinify that? How do we collect enough data, and how do we propose a model to really understand not only the performance in terms of population, health, delivery or care, but the sustainability from the economical standpoint during quiet times, if there are so quiet times, and during crisis. And I will show you a couple of examples for that. So first a little demo. The demo that you are going to see here is a little effort that we are trying to do, and here the topic is really the multimodality. We understand, depending on the therapeutical areas, but more globally, that we need to be able to provide to our collaborators, to our partners, technology that by definition, at the foundation of technology, is multimodality enabled. So all the different formats, all the different structures of data. Imaging, there are DICOM, but there are many. PET scan, angio, ultrasound, IRM, you name it, MRI, you name them. And of course, PDFs and so forth. We want to have a platform that is agnostic enough, yet integrative enough to cover at least 80% of the needed data per therapeutic areas, practices, and challenges. And this is what this video will show with sound, I hope.
Cardiovascular diseases are a group of disorders that affect the heart or blood vessels. They are strongly intertwined, making it difficult for cardiologists to have an integrative view. Let's follow the hypothetical case of Sarah Spencer from a family with dyslipidemia disorders. She had a previous condition of an atrial fibrillation ablated 6 months ago. She has been experiencing dyspnea on exertion for a few weeks. The cardiologist opens the virtual twin of the patient and checks the accessible assessment of the cardiovascular KPIs, rhythmic function, ventricular contractile function, and the vascular impact evaluation of the previous elements. Since the rhythm function is not related to the dyspnea, the cardiologist looks at the assessment of the contractile function of the left ventricle. Ultrasounds are the preferred modality to check the cardiac function. In this view, all anatomical structures are visible. To compute relevant biomarkers of the cardiac function, we perform a wall tracking through a motion estimation which uses a modified CNN trained on synthetic databases, including a realistic echocardiographic database. We can detect the endocardium, the innermost layer of tissue, and the myocardium, the middle muscular layer responsible for the contractile function of the cardiac pump. The contour is analyzed to compute the ejection fraction. This biomarker measures the ability of the heart to pump enough blood to the body and is normal when it is higher than 50%. In our case, the ejection fraction is about 44%, meaning that it is mildly reduced. The curved shape of the global longitudinal strain, or GLS, indicates if the muscle is contracting well. A GLS superior to 18% is normal. In our case, the GLS is about 14%, which means a reduced systolic function. The heart failure may have impact on the peripheral vascularization. We choose the brain as an example. The cardiologist uses Sarah Spencer's virtual twin to see if her heart failure could lead to an insufficient perfusion and oxygen supply to the brain. First, non-intrusive ultrasound measurements are used by a neural network to calibrate the patient's artery parameters. Then, a second neural network simulates the hemodynamics in real time. This pipeline gives us a full ModSim personalization tool. Sarah Spencer's virtual twin contains her available ultrasound measurements in multiple arteries. Before the personalization, the parameters are set to represent an average patient's anatomy. Fitting the simulation to all the ultrasounds is a complex task that requires tuning more than 300 parameters. The calibration neural network gives an automatic personalization of all the parameters and all the arteries. The simulated hemodynamics are now able to fit the patient's ultrasound measurements. We can finally analyze the unmeasurable hemodynamics of the patient's vascular system and assess the patient's blood perfusion in the brain arteries to check if it is impacted by her heart failure. But what confidence can the practitioner give to these predictions? There are multiple sources of uncertainties when personalizing a virtual twin: measurement noise, knowledge error, and simulation error. We are currently exploring uncertainty quantification in our ongoing advanced PhD in next-generation simulation. By propagating a noise model, we were able to quantify the uncertainty of the ultrasound measurements and predict multiple outcomes. The practitioner can now estimate the confidence they can have on the predicted perfusion values in the brain artery. And they can conclude that even in the worst prediction, the blood supply to the brain is sufficient. Therefore, the cardiologist prescribes a treatment to protect the patient from the symptoms of her heart failure. The cardiovascular virtual twin is the fundamental base to support the vision shared by our medical partners.
So you've seen on that video, not only we want to support different kinds of modality, but understand the semantics related to those kind of modalities. We know that, for example, some format are used only for certain medical act, and some others are in the same patient journey, but not revealing the same semantics. So how do we leverage them and standardize them all together to do comparison? And after that, of course, we have the power of the modeling and the simulation to project and simulate, and we hope to use AI also to have near real-time kinds of simulation, because, of course, if you are visiting a doctor, you don't want to wait 2 hours or 48 hours waiting for the simulation results. So we want something at the doctor's office and during consultation. And in fact, and this is what you see here, remember Bernard showed you this pyramid. This pyramid that we call the knowledge know-how pyramid is really, if you will, our frame. We want to start from the bottom, which is the multimodality of the data. And we are not limiting ourselves to all kinds of data, which is a huge undertaking. And after that, we want to use our structured view of the medical knowledge and know-how to provide higher abstraction and higher representation where those data would fit and connect all together. And you could ask, but how do you use AI then? And you see some example here. The AI at every layer of that pyramid is bringing some added value to, for example, connect the different formats, to infer biomarkers, to relate to some structured modeling, and to do let's say, the know-how synthesis. So you need to understand that in Dassault Systèmes, we are not only, let's say, adding technology on top of the others. Right now, there's a whole fuse effort to really have new modeler techniques to be able to apprehend the noisy and uncertainty of the living from the data acquisition, and uncertainty qualification for the simulation as well, with the help of AI. And you will have, I'm just teasing here, but for those of you who are not planning to stay the whole day, you need to, because you will have more secret revealed by Dr. Eloi Meyer, who is, let's say, at the heart, pun intended, of this revolution. I'm switching to the second floor. And this is something we started to present publicly. Of course, as I said, human twins are something which is a huge undertaking. It's going to take us the next 15 years. But at the same time, we cannot do that without looking at where this is happening. So, for example, hospitals. And you see here different projects that we have undertaken. Who says that we cannot try to use the power of the virtual world, modeling, simulation, and AI to try to help the performance of a hospital? And I see some practitioners frowning. Wow, this is maybe naive. We don't think it is. At least we need to try. Let's put it this way. And you see different layers on top of that. Of course, we can reconstruct a 3D setting of a hospital to understand the different pathways and the different journeys of the practitioners, of the staff, of the equipment, of the resources, and of course, ultimately, of the patient. But we can also use existing technologies that are, let's say, industry-proven in adjacent fields to help cope with the unexpected event of a day, to try to have a more adaptive scheduling for the professional staff, and also to try to anticipate the availability, the provisioning of either expertise or equipment. And this is what we do. So you're going to see a next video, which is a tiny illustration, where what we do, we model processes we do process mining from a hospital, and on top of that, we try to present a more globally 360 understanding of what is going on in a hospital.
Automating hospital operations is crucial to increase hospital efficiency and the safety of cares, to improve patient satisfaction and the quality of working life. This must be done through the automation of patients' journey. When all the hospital reference pathway processes are already deployed in Interop, the coordinator, responsible for their modeling and monitoring, could analyze them in the tool to quickly detect high-level issues. Here, the coordinator observes that revascularization takes longer than expected in the treatment of carotid stenosis. In-depth investigations are possible through conformance checking indicators tailored to patient journeys. They highlight deviations between the modeled and actual journeys and proposes modifications to fit the reality. Here, we see that the model misses a stretching step after revascularization. Since this step is not modeled, stretcher is booked on the fly subject to resource availability, while the patient is waiting in the intervention room. The coordinator discusses the outputs with field experts who will validate the proposition. They can also suggest other improvements that require expert knowledge. To update the model, the coordinator can simply ask an agent in natural language. The agent modifies the Interop process that is automatically configured and immediately deployed. This process enables to book the required resources as soon as allowed in the pathway. It is easily adaptable to different hospital time management software thanks to ItterOP services connectors and API. Time-aware indicators about resources are also available. It gives statistics about the duration of resources utilization and shows type of resources that are over or under leveraged over a time window. Here it shows that ICU beds were overused every day of the previous week. Thanks to an augmented reality headset, the coordinator can investigate the problem with ICU bed via an immersive experience, which reveals some faulty material and a constant overuse. Now let's shift to a view where we explore the strategic planning of consultation boxes. In this view, we have a dashboard displaying performance indicators and various statistics, alongside a GenAI assistant. The goal here is to use the assistant to optimize resource allocation through an interactive multi-objective optimization process, guided by user preferences expressed in natural language. Additionally, after each optimization, the assistant generates a natural language explanation, ensuring users understand the rationale behind the decisions. The GenIA assistant functions within a multi-agent framework, where distinct LLM agents handle different types of requests. When a user interacts with the assistant, their request is first processed by a selector agent, which determines the appropriate agent to engage. For example, specific agents are tasked with generating new schedules, identifying the best medical specialties to hire, or crafting hypothetical scenarios. For example, we asked the assistant which specialist to hire to improve the transformation rate. It recommended an oncology specialist, explaining that they significantly boost the rate from week 10 with a minimum of 3 vacations per week. Now, let's move to the next view, where we focus on the regulatory management of schedules in response to unfolding events. This view features a dashboard with 4 key indicators and a GenIA assistant. The user interacts with the assistant to handle these events as they arise, updating the schedule in real time. Additionally, the user receives textual explanations from the assistant, ensuring that each update is clearly understood and aligned with the current context. This dynamic interaction highlights the GenIA assistant's role in maintaining flexibility and responsiveness in schedule management. Technically, when an event occurs, we use a first LLM to detect the nature of the event, whether it's a doctor's absence, a patient no-show, a closed consultation box, etc., and format this event into a standardized data structure. Next, we call upon an optimization solver to update the schedule in response to this event, adjusting the optimization program as needed. Finally, another LLM is employed to generate a textual explanation. This LLM takes into account the event, the previous and updated schedules, and the specific adjustments made to the optimization program, providing a clear and comprehensive explanation of the changes. Here, we will explore examples of user requests made to the GenIA assistant, showcasing how it efficiently processes real-time scheduling events and provides clear, tailored responses that reflect the adjustments made to ensure optimal schedule management.
So you've understood. I will stop a little long. And finally, with time, because I'm already exploded the agenda, the last part, which is the last floor that I discussed in the beginning, which is the healthcare system itself. Of course, this is a very long-term initiative, and we are, let's say, creating an alliance with partners for that. The idea is to try to understand from an economical standpoint, macroeconomical standpoint, the sustainability of the different existing health systems in the planet. We know that in France, we have our specificities. In the US, there are other specificities. In Netherlands, Israel, Japan, there are classes. And so let's see what it entails as a first twin of a macroeconomical health system.
Healthcare systems are complex ecosystems of hospitals, clinics, physicians, nurses, drug providers, firms, administrations, and of course, people. In this universe, the stakeholders do not necessarily share the same goals, and public policies try to maintain a balance between these various objectives. These complex universes can be conveniently represented by a complex system of systems divided into 4 main components: the population, the health providers, the financial part, and the public policy sector. In the last years, Dassault System has developed a powerful modeler, the General Population Dynamics Modeler, which is based on the structured Mac Kendrick formalism. A vast range of systems can be described by our approach: demography, epidemiology, population dynamics, economics, and of course, healthcare systems. Our knowledge of a system is first encoded within a set of diagrams. The modeler will then generate a full systems of equations, sometimes containing as much as 10,000 equations, which can finally be simulated with advanced solvers in CATIA systems, or DEMOLA, for instance. We are familiar with some of these diagrams, like the financial one, representing the various monetary flows between actors, funding, payments, reimbursements, and so on. Or like the patient journey diagram, which represent flows of patients going to hospitals or town doctors for urgent cares, non-urgent cares, or preventive care visits. We have demonstrated our ability to generate models corresponding to different countries with 2 very different examples. France and the United States. The model generation is also valuable to try answering old and new questions in public health policy and see how the health universe would react to modifications of these policies. Let us consider an important example: cardiovascular diseases. In France, 15 million people have cardiovascular-related problems. They are the second cause of death after cancer, including 50,000 heart attacks each year with a 5% survival rate. Many risk factors are known to play a role: smoking, alcohol, lack of physical activity, obesity, stress, hypertension, diabetes, and so on. One of the main ideas to reduce this prevalence is to increase the number of preventive care visits to have a better monitoring of patients and follow more closely their situation. The model has to be modified to take into account the specific situation of cardiovascular diseases. Let us zoom in the patient circuit and consider preventive care visits. Obviously, one has to distinguish cardiovascular-related visits from other visits. We must also distinguish in the population with chronic diseases, or chronic and urgent diseases, the people who specifically suffer from cardiovascular problems. After the modification of these diagrams, a new model can be generated, calibrated, and simulated. The simulations performed on the modified model and for the 2024 to 2044 time period show that a 10% increase of the cardiovascular preventive care visits in a 10-year period could slightly decrease the number of people suffering from cardiovascular diseases and, most importantly, the number of deaths. This comes at a cost, however. Without increasing the number of physicians, this would slightly increase the delays for the rest of the patients to access to the physicians. Therefore, there will be a slight increase of the number of people with chronic diseases. The adoption of virtual solutions for the monitoring of some patients' issues can be of great help to reduce consultation time, thus freeing time for the rest of the patients. Assuming that a slow increase in the adoption of virtual twins and monitors over the 2024 to 2044 period would reduce consultation time by 10%, the simulations confirm that the general population would not suffer from an increase in the number of cardiovascular preventive visits. Additionally, the decrease of the number of people with chronic and severe cardiovascular diseases would also lead to a slight decrease of the cost associated with these visits. Notice, however, that the cost associated with the acquisition of the devices themselves is not taken into account here. Let us end by emphasizing some of the most important perspectives made possible by this approach. Any preventive and incentive policy can be represented inside the model by modifying the appropriate diagrams. By using optimal control tools on these modified models, it is then possible to choose between these various levers to draw future trajectories that may be very promising regarding various health KPIs, enabling new policies and health system experiences for a better health and healthier people.
So why are we, again, looking at this? If new medical acts in the future rely on twins, there's going to be question of reimbursement, there's going to be question of value in the setting of value-based outcome health. And so we not only want to tackle this by just a medical act by itself, but by its consequence in the longitudinal setting at different region or national. I'll end with this because I'm already beyond the agenda. Again, like Claire said yesterday, please look at our update of the white paper because those 3 layers are very well grounded and listed there.